Hi guys, today I was not going to post anything because I was feeling super tired, but still I thought that one topic is there from opthal which if covered would be nice in the video, that is thyroid eye disease from the subject ophthalmology. So let's start with thyroid eye disease. Guys, in this video I have not made notes for thyroid eye disease. I'll just cover it from the textbook and try to simplify it in a better language. Thyroid eye disease. The term thyroid eye disease denotes typical ocular changes, that is changes in the eye. What changes? Lid retraction, then lid lag, proptosis, that is forward displacement of the eyeball. These changes have been labeled as endocrine exophthalmos, that is bulging out of the eyeball, and endocrine, that is because of some endocrine function, malignant exophthalmos because of some tumor, dysthyroid ophthalmopathy, that is because of ophthalmopathy due to thyroid dysfunction, then ocular gravis disease, gravis ophthalmopathy, and thyroid associated ophthalmopathy. Talking about etiopathogenesis, guys, thyroid eye disease may be associated with hyperthyroidism in 90% cases, hypothyroidism in 4% cases, or even euthyroidism in 6% cases. Risk factor: female sex 4 to 6 times more common than males. Smoking risk is directly related to number of cigarette smokes per day. So cigarette smokers, be aware, don't smoke so much cigarettes because otherwise it may have a risk of developing this thyroid eye disease. Okay, that's true, but still jokes apart. Middle age, most cases occur in middle age. Autoimmune thyroid disease, HLA-DR3 and HLA-B8. Talking about pathogenesis, thyroid eye disease is being considered as an autoimmune disease. What is autoimmune disease? Autoimmune disease because some defect in immune tolerance of the patient, with orbital fibroblast as the primary target of inflammatory attack. What is orbital fibroblast? Fibroblasts are cells which basically make up the orbital structures, and it's very important that the target of inflammatory attack are these orbital fibroblasts and extraocular muscles. Those are our rectus and levator palpebrae orbicularis, and we have ocularis orbicularis oculi, levator palpebrae superioris. All these muscles, these being secondarily involved. It is therefore probable that a target antigen is shared between the thyroid follicular cells and orbital fibroblast. Very important. Second, T cells probably act on the fibroblast adipocyte lineage within the orbit and stimulate adipogenesis, fibroblast for proliferation, and glycosaminoglycan synthesis. So these three steps. Extraocular muscles are enlarged, and as a consequence due to edema and infiltration with round cell. Orbital soft tissue shows increased amount of acid mucopolysaccharide and infiltration with lymphocyte, plasma cell, macrophages and mast cells. Clinical profile, clinical features, lid signs. As we discussed earlier, the lid signs basically retraction of upper lid. So that's the retraction of the upper lid. As you can see, this upper lid has got retracted. Next is basically the characteristic staring and frightened appearance known as the delirium sign. Can you see this? Delirium signs is the most common and earliest clinical feature in 90% of cases. Lid lag known as one graphis sign. When globe is moved downward, the upper lid lag behind. So this is 50% cases in which you can see. Then fullness of eyelids due to puffy edematous swelling and Roth signs. Next is difficulty in eversion of upper lid, Gifford sign, and infrequent blinking, Stelwax sign. Next, what we have is the increased pigmentation of lid, Jelinek sign, and poor forehead wrinkling on looking up, Geoffroy's sign. Conjunctival signs including deep injection and chemosis. Pupillary signs are of less importance. Next, ocular motility defects. What are these? Also, what here is to understand is that chemosis is nothing but edema. Ocular motility sign, Mobius sign. Those Mobius signs basically which range from convergence weakness to partial or complete immobility of one or both extrinsic ocular muscle in 40% of cases. And the most common ocular motility defect is unilateral elevator palsy caused by involvement of inferior rectus muscle followed by failure of abduction due to involvement of medial rectus muscle. And it is important to note that due to restricted ocular myopathy of the eyeball may be deviated towards the action of involved muscle with restrictions of ocular motility in opposite direction. For example, in medial rectus involvement, the eyeball may deviate medially with the restriction of abduction in spite of lateral rectus being normal. Exophthalmos. Exophthalmos being the second most common and classical sign of the disease. As a rule, both eyes are symmetrically affected, but it is frequent to find one being more prominent than the other. Even unilateral proptosis is not uncommon. Thus, grave ophthalmopathy is the commonest cause of unilateral as well as bilateral proptosis in adult, and in majority is self-limiting. This statement is, guys, very important. Exposure keratitis and symptoms of ocular surface discomfort. This includes sandy or gritty sensation, lacrimation, and photophobia. Corneal exposure has been attributed to upper lid retraction, exophthalmos, lagophthalmos, inability to elevate the eye, and decreased blink rate. Optic neuropathy, it occurs in about 60% of cases due to direct compression of the nerve or its blood supply by the enlarged rectus muscles at the orbital apex, and it may manifest as papilledema or optic atrophy with associated slowly progressive vision impairment. Classification. American Thyroid Association has classified Graves' ophthalmopathy, irrespective of hormonal status, into following classes, characterized by the acronym NO-SPECS, which means class 0, N, no signs and symptom, class 1, O, only signs, no symptoms. Signs are limited to lid retraction with or without lid lag and mild proptosis. Class 2, S, soft tissue involvement with signs as described in class 1 and symptoms including lacrimation, photophobia, lid or conjunctival swelling. Class 3P, proptosis is well established. Class 4E, extraocular muscle involvement, limitation of movement and diplopia. Class 5C, corneal involvement, exposure keratitis. Class 6S is sight loss due to optic nerve involvement with disc pillar or papilledema and visual field defect. Next is U-Go-Go classification of the severity of ophthalmopathy. Okay, let's once again see this. Class 0, no signs and symptom. Class 1, only signs, no symptom. Class 2, soft tissue involvement with signs. Class 3, proptosis well established. Class 4, extraocular muscle involvement. Class 5, corneal involvement. Class 6, sight loss to optic nerve involvement. Management of patient with TAO depends on... Sorry guys, if I told I'm extremely tired. Basically, severity of ophthalmopathy, which is established according to impact of the disease on patient's quality of life and risk of vision loss, and the disease is classified as mild to moderate, severe, or life threatening as follows. Mild TAO, characterized by thyroid associated ophthalmopathy, have a minimum impact on the patient life, and this usually presents with one or more signs. Minor lid retraction less than 2 mm, mild soft tissue involvement, exophthalmos less than 3 mm, transient or no diplopia, corneal exposure, responsiveness to lubricant. Then we have sight threatening TAO and moderate to severe TAO, thus increased signs and symptoms such as choroidal fold, ocular globe subluxation, disc thyroid, optic neuropathy. Talking about clinical course, thyroid disease, self-limiting disease 1 to 5 years, longer in smokers. Be aware smokers as compared to non-smokers. Congestive or active phase of increasing severity is characterized by active inflammation with marked lid edema, conjunctival chemosis, that is edema, and congestion. Increasing exophthalmos within 2 to 3 years. Fibrotic or inactive phase, basically quiescent burnout phase. Diagnosis, clinical diagnosis, What is it? Clinical diagnosis is not difficult in advanced cases of Graves' ophthalmopathy with bilateral proptosis. Next, what we have is investigations. Thyroid function test, all these things. Thyroid autoantibody assay, globulin, and thyroid-stimulating antibody US for extraocular muscle involvement. Then computed tomography scanning, CT scanning, proptosis, MRI, T2-weighted and STI, better soft tissue resolution and identifies active disease. Management, periodical clinical workup, non-surgical and surgical. Periodical clinical workup, it's essential to document the clinical course of disease periodically to require to effect of therapy. Clinical activity score, score 1, 2, retrobulbar pain, pain on ocular movement, pain. Redness, leads and conjunctiva for 3 and 4. 5, 6, 7, 8, leads, conjunctiva, caruncle, proptosis more than 2 mm over 1-3 month. That's for swelling. And loss of function, decrease in eye movement plus minus 5 degree over 1 to 3 month. And ocular motility workup. In addition to eye movement, ocular motility workup should also include field of binocular single vision, field of unicular fixation, and his or list charting to decide the intervention required. Non-surgical management requires smoking cessation should be insisted with the patient as it may markedly influence the course of disease. Head elevation with at night and cold compress in the morning helps in reducing the periorbital edema. Lubricating artificial teardrops instilled frequently in the daytime and ointment at bedtime are useful for relief of foreign body sensation and other symptoms of dry ocular surface. Eyelid tapping at night prevent complication of exposure. Guanethidine 5% eye drops may decrease lid retraction caused by overreaction of malar muscle. Prisms may be prescribed to alleviate annoying diplopia until the quiescent phase, and systemic steroids should be indicated in acutely inflamed orbit with rapidly progressive chemosis and proptosis with or without optic neuropathy. Radiotherapy 2000 rats given over 10 days period may be helpful in reducing the orbital edema in patients when steroids are contraindicated. However, radiotherapy may transiently worsen the disease, and combined therapy with low-dose steroid, azathioprine, and radiation is reported to be more effective than steroids or radiotherapy alone. Talking about surgical management during active phase, orbital decompression may be required for an acute progressive optic neuropathy or exposure keratitis in patients who are not respond to energetic steroid therapy. During quiescent burnout phase, the surgical management is required to improve function and cosmesis, and a stepwise surgical approach starting with orbital decompression if required to restore normal globe position, followed by extraocular muscle surgery for diplopia if still persisting, followed by eyelid surgery is recommended. Alteration of this sequence may lead to unpredictable result. Orbital decompression may be carried out by an external or endoscopic approach and may involve 2, 3, or 4 valve, and 2 wall decompression in which part of the orbital floor and medial wall are removed and allow 3 to 6 mm of replacement of globe. 3 wall decompression, it involves the removal of parts of the floor, medial wall and lateral wall, and allow about 6 to 10 mm of retroplacement of globe. 4 wall decompression involves the removal of lateral half of the floor and large portion of sphenoid at the apex in addition to 3 wall removal as above, and this allowed 10 to 16 mm of retroplacement of globe and is indicated very rarely in patients with severe proptosis. Next being extraocular muscle surgery should be carried out after orbital decompression since the latter may alter the extraocular motility. Extraocular muscle surgery in the form of a recession is required to achieve binocular single vision in the primary gaze and reading position, and inferior rectus recession is the most commonly performed surgery. So this treatment is very important. Eyelid surgery is required should be undertaken as extraocular surgery may affect the lid retraction. As a temporary measure but definitive Mueller LPS muscle should be used by the patient. Muellerectomy, levator recession, disinsertion, scleral graft, recession of lower lid retractor, and blepharoplasty. So yes guys, that's all. Thank you so much.